First of all, I would like to thank Professor Dr. Rida Kamel and all the organizers of Rhino Egypt for giving me the chance to be a part, as usual, of that international meeting. My topic today is about the global pandemic, the COVID-19, and my topic title is the early recovery patterns of olfactory disorders in COVID-19 patients, a clinical cohort study. My name is Dr. Muhammad Amir. I'm Assistant Professor of Otolaryngology, Tanta University. Starting with introduction, the coronavirus disease is caused by the severe acute respiratory syndrome coronavirus 2. It's a worldwide pandemic and it was first reported in China in December 2019. Till the time of writing this article, more than 114 million confirmed cases are distributed according to the World Health Organization. The British Association was the first to confirm that the loss of sense of smell and taste are significant symptoms, and they were found even in the absence of other symptoms in the COVID-19 patients. The data obtained from the literature suggested that most patients with anosmia or ageusia recovered within 3 weeks after infection, with tendency to persist for longer duration in other patient groups. Further study were needed to figure out the olfactory recovery pattern in those patients as reviewing their characteristics. The aim of the work was to delineate the different pattern of olfactory disorders recovery in patients with COVID-19. As regard to the methodology, we performed a cross-sectional cohort study on 96 patients attending the Tanta University Hospital with recent olfactory complaint that was confirmed to be a positive COVID-19 infection. The diagnosis was established by using the positive PCR on a nasopharyngeal sample. All the participants, which more than 18 years old, have been included in the study once the diagnosis has been established, and whether they were subsequently admitted to the hospital or housebound. In our study, we excluded the anosmia patients with history of olfactory dysfunction, patients not confirmed to be COVID-19 positive. Also, we excluded the patients with history of nasal surgery or sinonasal tumors, as well as the patient admitted to the intensive care units, mentally confused patients, psychologically disturbed patients, and illiterate patients. The studied group was inquired for age, sex, history, general disease, nasal disease, associated COVID-19 symptoms, and smoking. All the participants were interrogated during regular medical visits on a weekly basis for 4 successive visits in order to estimate the severity of this sensory dysfunction. We adopted a 10-item questionnaire. This item were adapted from previous international validated studies. Each item in the scale was scored from 0 to 10. 0 was equivalent to the absence of symptoms and 10 to a maximum symptom. However, complete recovery was defined by a score between 0 and 5 out of 100. Partial recovery was defined by a score between 5 and the score obtained during the previous visit. No recovery was defined by the 4th week, was defined by a score equal or superior to the first score obtained during the first visit. We analyzed the different associated factors affecting the pattern of recovery and the time lapse between the partial and complete recovery. As regard to the results, 96 patients completed the study. 65% were aged under the age of 40. The mean age for patients was 34 years old. There were 56 females and 40 males. 16.7% of patients were smokers. As we can see in that figure, that most of the patients in our cohort were aged between the age of 20 and the age of 40. 32 patients experienced full recovery, while 40 patients showed only partial recovery within 1 month from loss of infection, while 24 patients showed no recovery within 1 month. When there was a full recovery, the mean time for partial to complete recovery was 7 days. Patients' olfactory alteration lasted more than 1 month in 25% of cases with no improvement. We can see in the diagram the different patterns of recovery during the 4 successive visits on a weekly basis. In that diagram, we can detect the different patterns of recovery according to the different age groups. In our study, more than 33% of patients, or even more, showed a complete recovery within 4 weeks, while 41% of patients show a partial recovery, while 25% of patients show no recovery after 4 weeks of follow-up. In that diagram, we show the different patterns of recovery and those patients are associated with other comorbidities and those patients showing the other COVID-19 symptoms. The exact pathogenesis of olfactory upset in such pandemic patients is still ambiguous. However, the SARS-CoV-2 seems to target the non-neural cell types in the peripheral olfactory system rather than directly affecting the olfactory neurons. More than 56% of our cohorts were females, with an evident female predominance. And this goes hand in hand with other multicentric studies tackling the same topic. And we attribute this female predominance as regard to the olfactory complaint to the fact that females have a greater concern for their health, as well as the decreased capacity of men to perceive olfactory disorders. Hyposmia patients showed better recovery than those of complete anosmia, especially in the first week of the follow-up, and we believe that is due to a lesser viral load in hyposmia patients with better status for viral clearing. The middle age group revealed a higher rate of olfactory recovery than the other age groups, and this goes hand in hand with the other studies that revealed the same results. In the current study, females represent more than 70% of those who completely recovered anosmia, and 60% of our cohort who showed partial recovery. The exact etiology for this sex difference remains unclear. It has been suggested that this may reflect the fact that androgen hormones, which have higher plasma level in males compared to the females, enhance the transcription and propagation of the virus. In our study, as well as other multicentric studies, patients with associated COVID-19 patient symptoms and those suffering comorbidities are associated with a more delayed pattern of recovery than those who do not suffer the same conditions. And we attribute their finding to the belief that those patients with coexisting comorbidities are more likely to have a poorer baseline well-being with a reduced recovery potentiality. On discussing the different management protocols, in the current study we offered no specific treatment for the olfactory dysfunction that accompanied the COVID-19 infection, as early reports suggest rapid recovery within few weeks. On the other hand, the European Rhinologic Society and the ENT of the UK Association advised against giving systemic corticosteroid to the patients with sudden olfactory dysfunction, since corticosteroids cause immune suppression. However, according to the area statement, it is advised to continue with the intranasal corticosteroids in patients with allergic rhinitis, even if those patients become infected by the COVID-19. On the contrary, some centers adopt using short course of oral steroids in patients with a persistent loss of smell for more than 2 weeks. They believe that this protocol seems to give better outcomes than observation. We were proud in Tanta University to publish the first Egyptian article discussing the otorhinolaryngological manifestation of the COVID-19 patients with detailed analysis of olfactory dysfunction and the pattern of recovery during the COVID-19 pandemic. Also, we were proud to register our results in the prestigious journal, the American Journal of Otolaryngology. And finally, to conclude, the sudden olfactory dysfunction is a common symptom in patients with COVID-19. Hyposmia patients recover more rapidly than anosmia patients. The middle age group carried the best prognosis in olfactory recovery. Females possess better potentiality in regaining smell after recovery, and the association of comorbidities worsen the recovery rate of olfactory dysfunction in patients with COVID-19 symptoms. And finally, thank you.